Good evening, ladies and gentlemen, honoured guests. I have to say it's a delight to see so many medical students here, young faces, many friends, Barry, Jenny. This is my last President's lecture, and I have to say it's been such fun doing this. But I don't want to take up your time unnecessarily. This evening, we've got a really super lecture from Sian Falder. And Miss Sian Falder is going to talk to us on the title of Saving Lives or Making Monsters, which I think is deliberately controversial. And that's good, because we need a wee bit of spice in our lives. The WHO has described burns as... You can't hear. Who can't hear? Right. Is that better? Can we hear now?
Yes.
Okay, I will work hard. Thank you for telling me, because there's no point doing a lecture if you can't hear. The WHO has described burns as the forgotten global public health crisis. In low-income countries and conflict settings, burns patients often receive delayed, inadequate and inappropriate treatment, leading to unnecessary suffering, disfigurement, disability and death. Ms. Sian Falder has been a consultant in burns and plastic surgery at Alderhay Children's Hospital since 2008. She qualified in medicine from St Mary's Hospital Medical School, but we won't hold that against you. She had a first-class honours in the history of medicine, showing, unusually for a surgeon, that she had interests outside of the operating theatre. She trained in plastic surgery in Bristol and Merseyside, and then took a fellowship year training in Australia. In addition, Sian holds a diploma of tropical medicine and hygiene from the Liverpool School of Tropical Medicine. And again, it's really important to note how a breadth of interests will have informed her career. So don't get too hung up on just going for the goal of becoming a consultant as fast as you can. Really important to explore your interests, whether it's a bit of history in medicine or a bit of art of medicine. These are important things. Sian is a clinical teacher within the Liverpool University, and I think you spent today in the university, didn't you? She has held membership in a number of national burns committees and has many publications on her topic. She's a reviewer for the International Journal of Burns and also an expert witness in child protection cases. She is the surgical lead for Interburns. This is a charity, a non-governmental organisation that is focused on improving global burns care. Sian has worked for many years on programmes in resource-poor countries, including Nepal, Bangladesh, Mongolia, West Bank and Gaza, Tanzania and Pakistan. Ladies and gentlemen, please could you welcome Sian Falder to the stage.
Thank you, Callum, for that really lovely introduction. And it is a real honour to be asked to give this lecture this evening. And it's also a real privilege because I get to talk to you about something that I feel really passionate about, which is the treatment of people with burns. And that's probably something that most of you don't really think about in your day-to-day lives. And when I say to people what I do, and I treat burns, I tend to get quite a strong reaction. And usually it's quite a negative reaction. So people will say something like, oh, you must see some terrible things. Or they'll say, oh, I can't really think about burns at all. This is something I can't contemplate. And it's made me think, why is that people have such a deep-seated reaction to it? And possibly you might think it's because of how burns are caused and what you imagine when we say burns. But burns can be caused from all kinds of incidents. So, for example, in children, my day-to-day work, and across the world for children, the most common cause of burn injury is scalds. It's children pulling hot drinks over themselves or getting burned in the kitchen. We've also had a spate of people being burned by frostbite. And that's been teenagers who've taken some nitrous oxide canisters, they're holding them between their legs while they inhale the nitrous oxide, and they've given themselves deep burns to their inner thighs. And the damage that can happen from burns is the same, whatever the mechanism of injury. But I'm sure that when you think about people who've got burns, you're thinking about flames, and flames have got a real power over human beings. So if I tell you that this building had a minor, earthquake caused it to fall, or there was a structural defect, you probably will say, what a tragedy. But when you see something like this, it hits you in the gut, because flames are so powerful. Humans have been looking at flames, controlling flames, for at least 1 million years. So we've been using flames to heat, we've been using it for light, we've been using it to melt substances, to make jewellery, to make pots, to make weapons. And it's also contributed to our civilization, because by cooking food, we've been able to absorb far more nutrients, we've been able to take on higher numbers of calories, develop our brains, and become the intelligent and sophisticated beings that we would love humans to be. But we also use flames for really destructive purposes. Now, when you're a kid, you probably thought being burned at the stake was kind of gruesomely fascinating and horrible histories sort of way. But when we think about people who've been executed by flames, I think it's a really powerful and quite malevolent way of getting rid of someone. Because you're not just killing the person, you're actually destroying the biological being of the human being. So it's not just the pain and suffering that we know that comes with flame injury, it's also the sequelae, what happens when you've had a flame burn, and we're all aware of that. But as I say, the burn injury is the same to the skin, no matter what the agent. And acid burns is another rather nasty mechanism of injury, and a particularly vitriolic form of assault, particularly against women. And you probably remember this photograph, this man who has been accused of assaulting a woman in London not so long ago, and this was the picture put up for his identification. And I think when you look at that picture, what you see is a man who looks distinctly wicked, somebody suspicious, somebody who could cause a nasty degree of harm. And partly we think that because he's got skin damage there, he's got a burn injury to his face from that incident. And this is something that people with burns have to encounter on a daily basis. So here's a man I admire greatly, James Partridge. So he was injured in a road traffic accident when he was 18 years old, and he founded a charity called Changing Faces. And that supports people who've got visible difference. So not just facial difference, but also any type of bodily difference. And he's standing here in front of an advert for a conference calling company. And the advert is saying, why would you put yourself through the horror of the daily commute when you can just do your work from home via a telephone? And in order to convey the horror of the daily commute, they've got actors there wearing masks, rather zombie-like masks, that show facial disfigurement. And James and his charity are saying, look, this is the world that people with burns have to live in, and they're being portrayed in this evil, as being evil characters. So when you think about that, you say, well, I wonder why facial disfigurement is something that's considered to be evil or horrifying or monstrous, and maybe there's something innate in that. And if we think about what we mean or what we understand to be monstrous and to be monsters, here are some characters that we probably all recognise really well. And what's fairly horrifying about some of these characters is the way that they behave slightly differently to their ordinary vicious animal by having those human characteristics, but it's the one on the bottom right that is human and recognisably human, but who is also altered and different, who we feel quite horrified by, who does bring a deep-seated fear to us, and we think this is terrible. So maybe there's a little bit of innate anxiety about these types of characters, but certainly when we go to the entertainment industry, they capitalise on this. They love to show us their villains to be scarred, particularly facially scarred. And this isn't just decades ago, these are recent villains, and burn scarring features very heavily in it. We live in a world at the moment where people are really concerned with beauty and how they look. But these are a few memes that I've lifted off the internet, and even these that purport to show that actually beauty is only skin deep. It's actually what you're like on the inside. These memes feed into that narrative as well, because what they're actually being proposed by is the beauty industry and by women who are exceptionally beautiful. And if you look at the quotes themselves, there's Jennifer Lopez, beautiful woman, saying, beauty's only skin deep. I think what's really important is finding a balance of mind, body and spirit. Well, that's rather lovely, but if you then look a little further and find the proper quote, what she's actually saying is, well, you might be beautiful when you're young, but later on you wear the face that you deserve based on the sort of person that you've been, which is a very Dorian Gray way of looking at the world, and certainly not very helpful for somebody with burn injury. And this type of attitude, you might say, well, this is all very philosophical, it's got nothing to do with real life. But actually, this type of approach has real-world decisions where people's medical treatment might be influenced. So I'm going to show you this case that you'll all know well of Alfie Evans, the poor little boy who had a terminal condition, who there was a withdrawal of care order at Alderhay, and this caused a great deal of protest. There were protest groups, there were riots outside the hospital, in the UK, across the world, and I say that is because Alfie Evans was a really beautiful little boy. And I put it to you, with apologies to this poor little 2-year-old, same age as Alfie, whose photo I've lifted from the internet, that those protest groups would not have been there if this child had had a withdrawal of care order. So this is also not just hypothetical. So I'll just share with you one of the terrible experiences that I had in Alderhay. And that was that when you're looking after somebody with major burn injury, what you do is you have to basically take off the skin that's burned and put a graft on. And taking off that skin is literally flaying a human being. It's a very emotionally draining and difficult thing to do. And you can only do something like that because you feel that what you're doing is in the best interest of the person. And we had a discussion, debriefing with people involved in the care of this child, including ICU. And somebody said, well, look, I think what you're doing is torturing the child. It was a nurse who was expressing her real concern for this child. And part of that concern was because she'd got bad facial burns and was going to be disfigured. And so the implication there is that you don't want to save this child because she's going to be ugly. So in a way, we're saying there's a societal uglyometer that means that you might not want to save the child. And for me, that's a devastating thing, as I said, because actually, if I'm not doing something that people think or that is in the best interests of the child, then actually I am causing harm, and that feels terrible. Subsequently, when we looked after another child with bad facial burns who did really well, who survived and had a good outcome, the transformation in attitude across the hospital was very noticeable, and so that's very positive. But it reinforces the message that people are thinking that if you are disfigured in this way, maybe it's not important that you should survive. So what happens to people who have massive injury or disfigurement? What is their quality of life like? Well, in general, it would be wrong to say that they've got a completely equivalent quality of life as a whole group. There are some studies of young people with massive burns whose quality of life is good. Other studies show that quality of life is a little bit lower. And in an adult population, we know that there are higher rates of post-traumatic stress disorder, social anxiety and depression, but that the outcome is not related in proportion to the severity of the injury. So on that basis, I would argue that we should be trying as hard as we can to save people who've been badly injured through burn injury. And that is exactly what we've been doing in high-income countries over the last few decades. And so if you look back 60 years, 80 years, someone in this country, in a high-income country with a burn of 30 or 40% was almost certainly going to die and certainly have a less than 50% chance of death. Whereas now, people with 95% burns, 50% of those people will survive. So, over the last 20 years or so, the focus has shifted a little bit from trying to get those burns patients to survive, because they do that, but to improving the outcome for those patients so that their quality of life is better. And this is a patient of a world-leading service about 20 years ago who survived a very severe injury. And I think we'd all agree that the outcomes there are not as desirable as what you would like. But I can show you that 20 years on, this woman who's very remarkable was treated at the same service. And even though she's had to put up with headlines like this, which again feed into the narrative that it might be okay for her, it was her boyfriend, not husband, but might be okay for her boyfriend to leave her because she was going to be ugly after she'd had a flame burn, she has come out extremely well. So she got caught in a bushfire as an Ironman race, and she's quite well known in her country as an advocate for burns, and her outcomes are really good. And so we have to think then, in our society, this is what we're driving at when we're treating burns patients. It's around keeping people alive, and it's about making things as good for them as we can. And to be honest, that is what everybody in society is doing. And this is how, just a little aside, how I look at plastic surgery. So with burns patients, they're outside the normal range. You wouldn't normally expect to see somebody with scars. So we are trying to bring them back to that normal range. But those who are, plenty of people in the normal range, are trying very hard to get themselves to the top end of that normal range, and that's what I would consider to be cosmetic surgery. And then there are those who are perfectly normal, who like to take themselves out of it and bring them back round full circle. So let's just go back to the history of high-income burn care then. So I said this is a graphic that I've devised. It's not a real graph of how progress has been over the time, but what it shows is how we've improved survivability and how things have plateaued off. And you can see that it's taken about 60 years to get to that plateau. So why is it that it's taken such a long time to make these advances in burn care? And the answer is because it's really difficult, and because we're talking about the skin. Now, if I say to you that you've lost 30% of your liver, or you've lost 30% of your brain, you'll accept that that's a catastrophic injury. But if I say to you, you've lost 30% of your skin, you might not really think that that's particularly significant. But it's worth remembering the skin is 16% of your body mass. It is a barrier. It's what keeps your insides in. It's what stops water getting in. It's what stops bacteria getting in. It is also the biggest immune organ in the body. It's what controls our sweating. So it helps our temperature control. We manufacture vitamin D through our skin, and it protects us from the sun. It's also a sensory organ. It's how we interact with our environment, and it's flexible so that we can move. And it's also, as I've been saying, it's our aesthetic interface with the world. So if you damage your skin, particularly if you damage above around 30% body surface area, you have effects on the whole body system. So it's not just the skin and the scarring, it's also the gut. You can't absorb food, you can't process it, you have a high risk of ulceration. There are endocrine disturbances, so children will stop growing during this period, and they don't make that growth up for a couple of years afterwards. You're at high risk of infection through bacteria coming from the gut as well as through the skin, and you have other major organ dysfunction, including your glucose metabolism, your cardiac function and your bone. And very significantly, major burns patients have a high metabolic response, which means that they lose weight, they go at a very high rate, and that can be really difficult to control and can lead to death for the patients. So let's look at how we've managed over the course of that time to bring about these advances in survival. So the first thing was fluid resuscitation in the 60s. And all these improvements have been driven by mass casualties, where there have been a lot of burns patients, and also war, which has been a big driver for advancements in plastic surgery. But anyway, the fluid resuscitation came about in the 60s, and what we found was that when somebody's badly burned, you lose a lot of fluid from the circulation into the tissues, and that means that those patients are likely to die of shock in the first few days after injury. So realising that if you gave fluid in proportion to the body surface area burned, you could save lives. The next thing was surgery. So prior to this, what happened was, if you had a burn injury, you'd be a bit like the English patient, you'd be wrapped up in your bandages, and basically the treatment was waiting until the body sort of autolyzed or dissolved away the burn tissue, and then maybe a month or two later you might be in a position to get a skin graft. And that changed with this lady called Zora Janzekovic from Czechoslovakia at the time. And what she observed was, why do we wait all this time for this vascular bed to appear? Why don't we just shave off the burn tissue and put a skin graft on much earlier on? And so, in a way that probably you couldn't do these days, she just went ahead and did that on a lot of patients and achieved really good results. So that was a big advance. Following that, sort of in the 80s, was in the special children's hospitals called the Shriners Hospitals in the States, was realising that if you excise the entire burned area quite early on, by which I mean within the first week or few days after burns, then you improve, you save lives, you have much better outcomes. But doing that cannot be underestimated as a logistical challenge. So on this side, you're seeing really the sort of standard operating setup if we're just excising a relatively small burn. On the other side, what you're seeing is somebody having a massive burns injury patient having the total body area excised. And in that setup, you can see there are multiple surgical teams, there'll be multiple anaesthetists, scrub teams, and this is a massive undertaking. Because you've got no barrier, it needs to be hot. So the temperature in theatre can be 30 degrees. You're scrubbed up, you're under the lights, and you might be there for 8 hours, even if there are multiple teams. There's a big risk of blood loss. You need to have blood transfusion capabilities. It's exhausting, and what you're doing is quite emotionally draining. And so once you've done this, it's important that you're able to cover the area that you've taken off. If you've got a 70% or 80% burn, you haven't got enough donor site skin for a skin graft. And so without the advent of a skin bank, you know how you can donate your kidneys or other organs, you can donate your skin. Without a skin bank, you wouldn't be able to cover those areas, and so the patients will die from sepsis. So the later developments have been around development of artificial skins, which can act as a temporary barrier while you find sufficient donor sites. So here's an example of that sort of artificial skin, and this is Integra. So this was one of the first ones in the 90s, and it's made out of collagen from cows and proteoglycans from sharks, and it acts as a template for the dermis, the bottom layer of the skin. You apply it to the burned area, you wait about 3 or 4 weeks, and then you can peel off the silicone layer, which has acted as a lovely barrier, and put a skin graft on the top. This is showing you how that works in a scarred patient rather than an acute burns patient. And just to put it in context, that piece of Integra probably costs now between £2,000 and £3,000. There is a cheaper version that's come out, developed by a professor in Australia, and that's really good because it's completely synthetic, which is better for people who have religious beliefs that mean that they don't want to use collagen derived from an animal, and it is also more robust and probably better for being used in a low-income country setting. You can also culture skin. So you can take a little skin graft, just about the size of a postage stamp, and send it off to the laboratory, and they will clone those cells and turn them into a whole batch of keratinocytes, which can be received as a spray after about 2 weeks, or received as a sheet of cells that can be applied after about 3 weeks. And to put that in context, a spray is probably about £400 or £500, and a 10 by 10 sheet of cells probably costs around £1,000. And in the meantime, you've still got stuff to do because it's 3 weeks away, so you've still got to use your donor skin in order to protect the patient. The UK has found it not cost effective to grow its own skin anymore, so you can't get cultured skin anymore in the UK, so we have to ask Switzerland for it if we want to be able to use it. So if we have one major burn patient in our unit, or in any unit, what resources does that take? Well, you can see there all the people, the staff or the roles that are needed to try and manage that person optimally. And that ranges from dietitians to therapists to psychologists to the people who work in the lab. And you've also got an inordinate amount of theatre time. So I just looked once at one of our patients to see how much theatre time did we use in the first 2 weeks. And I think we used somewhat over 50 hours of operating time. And then following that, a patient will probably go back to theatres maybe twice, sometimes 3 times a week for a period of 2 or 3 months. So it's extraordinarily intensive in the resources that are required. A patient with a major burn will stay in hospital for 3 to 6 months. There's a patient I know of in one of the units in our country that's been there for 18 months. And the cost of these patients will be around £250,000 to £500,000 if you've got a burn of 70 or 80%. And for these people, they will be coming back with multiple interventions over a number of years. So if we just think about what would happen in the event of a mass casualty with burn patients, this is published just recently by the NHS as what they will do in a mass casualty scenario. And what it says is, this is talking about adults, that 10 major burn patients as adults would be okay, like we'd be able to manage that, but 20 would probably not overwhelm, but would certainly impact on capacity and impact on normal business continuity for the NHS. And in children, that is fewer. So recently, when 3 children were admitted to Manchester at one time, we had to take one of those patients. And 10 major burn patients would probably overwhelm the UK, and we'd need to ask for international assistance. So what we found is that over this time period in the UK, in high-income countries, the number of burns patients is really falling. And that's thanks to our wonderful fire service. And I have put this picture up, partly because it amuses me, because it's Fireman Sam, but a couple of those characters looks like they've been based on my husband and my son. But that's as an aside. The fire service have done this remarkable job of putting sprinklers, fire alarms, smoke detectors in our houses. We've got health and safety legislation that stops us having flammable clothing, stops us having flammable furniture, and it means that we're in the situation where there are a handful, there may be, there were less than 5, probably 3 major flame burns in children in the last year. So what we're doing is we meet once a week. If there's a patient anywhere in the country, the burn surgeons and teams will have a national multidisciplinary team meeting. So if somebody's admitted in Birmingham, I will join a meeting, partly to give advice, partly to keep up my skills. So good news for children. So you might be saying, well, why am I standing up here talking to you and saying that burns is a global public health crisis? Well, that's because across the world, burns remains a major problem. Now, these figures, I couldn't find anything more recent, were taken in 2011 from the WHO website, and we know that there are millions of people sustaining burns every year, and there are hundreds of thousands of deaths. And it is one of the highest causes of disability globally. And that's because houses are built out of poor materials, close together. People are still using flames for cooking, for heating and for light. And so the opportunity for injury is higher. And people are wearing flammable clothes, there's flammable materials within the buildings, and children are not well supervised, and the disproportionate amount of burns in women and children in low and middle income countries, particularly in Africa and Southeast Asia. We also know that electrical safety is poor. That's due to low-hanging electrical lines, it's due to people flying kites when they're standing on buildings, it's just due to poor safety. And if people are not well managed in terms of their medical conditions, such as diabetes or epilepsy, then they may find themselves unconscious and sustaining a burn. And unfortunately, flame homicide or acid attacks is also a problem, particularly in Southeast Asia. The root causes of burns across the world, which we've dealt with a little bit better, but actually is still prevalent in low-income countries. It's poverty, ignorance, greed, risk-taking and conflict. And you can see that illustrated well with some of the mass casualty disasters that take place across the world. So in the Congo, for example, they have a lot of problems with people trying to steal fuel from the tankers when a tanker breaks down, and then that leaking fuel causes an explosion and hundreds of people are injured and there are large numbers of deaths. And similarly, those root causes also contribute to a number of deaths and injuries in things like the factories, clothing factories in Bangladesh. And we probably don't have to say very much about all the conflicts that are taking place across the world, but I think what I've been showing you is really, you can see what it must be like to sustain an injury in those environments. So if we go back to our graphic and say, well, where are low and middle income countries in this sort of trajectory of burn care, we'd say generally they're about here, they're about 50 years behind. So what that means is they don't have access to the technological developments, the skins, the dressings that we've got. They don't have they haven't got any artificial skins, they haven't got the resources for that. They don't have the logistical ability to be able to do the total excision, and they don't have the surgeons that are needed to carry out burn care. And you might say, well, why don't they have the surgeons? And that is a very good question. If you were an alien and you were looking at the Earth, would you not be gobsmacked by the way we've got it arranged? I mean, this fact is staggering, don't you think? That the richest 1% own nearly twice as much as the rest of the world put together. That is just outrageous. And the other two statements there come from the Lancet's Global Commission on Surgery in Lower Middle Income Countries. And what you can see it says is that of all the millions of operations that take place across the world, only 6% take place in resource-poor settings where more than a third of the world's population lives. The discrepancy in our world is quite remarkable. So what does it mean if you don't have a burn surgeon? So this is the only medical picture that I'm going to show you, so you might not want to look at it. But what I'm showing you is a boy who's just been treated in the way I was describing, who hasn't got a life-threatening burn, shouldn't be life-threatening. It's not a very big area. And he's been treated in the way of not having anything done, just waiting for the body to sort of dissolve the tissue. And this is what you see. You see somebody who's had pain and suffering for at least a couple of months, and when the body is trying to heal that, it will shrink as much as it can. And because there hasn't been sufficient positioning, there hasn't been skin grafting, it's going to heal with contractures. So when we're talking about improving care in low and middle income countries, I think what we have to think is that it's not about trying to save the lives of those with massive burns. That's what high income countries have been focusing their time on. It is about preventing the disability that results from poor care for those that have got smaller burn injuries. And you can see that none of these burns are very big, but they're all hugely significant on the impact that people have in their lives with this. And just showing you these two poor boys where, you know, really that's a crime that anybody should be in that situation. So when Barry said to me, as I started my consultant job, would you like to go to Nepal and do some burns? I was thinking, well, that'll be fun. And Alder Hay and Kanti Children's Hospital in Kathmandu have had a partnership over a long time now. And I went along to see what the burn situation was like. Oh, do you need to, do you want me, yeah. Shall we pause, Callum? I hope I haven't made anyone feel too unwell. Shall I just see if they're okay, and then I can carry on if everything's all right? Yeah, shall I carry on? Yeah. You think so? 5 minutes. Our ICU colleagues have gone, so they're in safe hands. There's proper doctors. Yeah, I think so. Yeah, if everyone's all right, then.
How long have you been going to County Hospital for then, Sean?
Since 2008. Yeah. So Barry said, do you want to do that? You go, yeah, that sounds okay, I'll go for a visit. And you don't really think that you're committing yourself to what's turned out so far to be 17 years of global healthcare. Callum, are we all right? Shall I carry on? Thank you. Yes, so I went to Kanti Children's Hospital, and this is what it's like, which is pretty standard for, or this was a few years ago, so pretty standard for the sort of situation that is in most sort of quite high status hospitals in resource poor countries, but this is one of the poorest countries in the world, and it's a far cry, is it not, from the wonderful hospital that we have now built in Alderhay, and that is exactly what a cubicle on my burns ward looks like. So I went to Canty and I met Dr. Chowdhury, who was the head of the burns unit at the time. And the reason I mention that is because I believe that it is really, as I'll come back to, relationships that are key to making any change in any system, but particularly when you're working overseas. And Dr. Chowdhury came to the UK and he stayed with my family for 4 weeks, and we got to be friends. And we agreed that we would try and work together to see if we could help develop burn care in Kathmandu. So we got a grant from the British Council and THET to enable us to carry out a project together to look at how we could make some changes. And it's a sad state of affairs, really, that the present government has taken away and changed the way that it funds overseas aid, because the money that it stopped funded projects like this, and we can't apply for those sort of grants anymore. So what we did was we did some training within the hospital, and we provided some training for healthcare staff outside the hospital around the city. We did a little bit of hands-on work over the course of a couple of years, and over about 6 or 7 years subsequent to our project, all the surgeons in that hospital came to visit Alderhay. And we did a proper evaluation of, what had happened in the work that we'd done together. And it's really difficult. You're not going to get outcome differences in a couple of years. But I think one of the things that I want to highlight is this comment when we did a subjective analysis, that before I used to think burns were too difficult, impossible. I had negative attitude. Now I feel more positive. With teamwork, we can do it. And I think that type of sentiment is really important. But what is very clear is that you cannot improve burn care by just popping across to a hospital, even as well-meaning a partnership as we were trying to do, to help trying to change things in one single environment. So what this is showing you is, here is a person in their community, and then they sustain a burn injury. And that might be by a whole host of different mechanisms. And then they may or may not get any first aid. They get transported to hospital. Once they've had their treatment, they go back out into their community, and one hopes they're then restored back to where they started. But if you want to make a change in burn care, you have to think about every single one of those steps. So from the start, getting burned. If you get an electrical burn or a high tension electrical injury, you've got a really serious injury. So if we can prevent those, if we can prevent flame burns in the same way that we've managed in high income countries, you are going to do the most good. Once you've sustained a burn, if you get first aid, that can make a significant difference. But if people don't know what to do, then they're going to have burns that are a little bit worse. How they get transported to hospital, whether they get transported to hospital, that's partly around education of the first provider, but it's also the transport infrastructure. And then they get into hospital where normally medical people are trying to make the changes. If those burns patients don't come back, or they're not given splints, they're going to develop contractures no matter how good your surgery might be. And if they don't get any psychological intervention, or no one tries to address the stigma, then they're not going to return back into their society as full members of their community. So it's really important to try and address all those areas. And the WHO has said, affordable, effective interventions do exist to reduce morbidity and mortality. It's just that people don't really know how to implement them properly across all the domains of healthcare. And so Dr. Chowdhury and I invited Interburns to come to Nepal and be part of the project at the time. And Interburns is a very tiny charity that was formed by an ex-colleague of mine with a view to try to improve burn care in low and middle income countries. And what is really good about this charity, the three things that I think that make it stand out, that are really excellent, is networking. So this is built on professionals, people who are interested in burn care, forming a network, a global network of working together to try to improve it. It is not just volunteers from one place going to another. Whenever we do run courses, we do it with international faculty. So I'm going to Abu Dhabi to run a big course on Friday, and our faculty come from the USA, Italy, the UK, some local people from Abu Dhabi, 2 surgeons from Nepal, 1 from Tanzania, and 1 from South Africa. So having a mix of international faculty is really important. It isn't a whole white group coming saying, well, look, you know, we work in the UK and this is how you should do it. It is bringing people from the right context all together to work together to improve care. And it's adopting a comprehensive approach. It's looking at all those areas that I've just showed you to make changes. And I'll just talk you through a few of those. So what we mean by a comprehensive approach is saying, well, what is our starting point? What are the standards for burn care? Once we've got those standards, we need to assess the services, the situation, the country against them. We need to implement changes that are going to improve and build capacity, and then we're going to re-evaluate where we are. So in 2012, we held a conference to agree consensus standards. And that might seem fairly run-of-the-mill now, but at the time, there were no UK burn standards, there were no international burn society standards. So what we did was get several leaders from different disciplines and different countries. I think we had 11 different countries, 13 different countries all together, and we agreed what are the minimum standards that you would expect if you're delivering burn care, no matter where you are in the world. And then, in order to look, if you're a service that wants to get better, how are you going to do that? We devised an assessment. Now, this is not Ofsted. I've just had a kind of medical Ofsted of our burn service. I can tell you it was horrific. My husband will attest to it. It took weeks of preparation to get everything ready for this external judgment on our performance. This is totally different. We devised 10 domains, the important domains of burn care, and within each domain we have some facilitated questions that the team in the hospital can sit down and work through together, and they will then grade themselves as to how they think they're doing in each of these areas. And that in and of itself can be a massive change. So team working is not always a concept in many of these countries, and we have worked in places where the teams have not ever sat down together. You don't get the head of department sitting with the nurses and a therapist and them all speaking openly about how the service has been delivered. So doing that has been in and of itself quite an improvement. We then take what they've discussed and we write a report for them and put it into this colour-coded format so it's very clear to see the areas they're strong in, the areas that need improvement. And working with them, we agree, what can you put in place that is going to make a difference? And not just that, but what can you do, what's in your gift to do, and what do you think is going to make the best outcome? You can also then carry it out again in the next year or the year after. And the benefit of that is that it will show you the changes, it shows improvements. It's great for donors because they can see that if they've put money into a project, you can see a response. And I personally have been involved in carrying these out in several different countries and remotely in Ghana, Malawi and Mongolia, and it works very well. So obviously training is one of the big things that is required. Most people in all these settings don't have any burns training at all, and so we've been working over a large number of years to devise appropriate training for the various people at these different points in burn care. So for example, basic burn care is a course that we train the trainers, if you like. So we're giving people information and materials on first aid and prevention at the community level. So this isn't loads of information, it's about what to do if you're running a health post in a district area, and then that will be taken and delivered in a local language. I just want to give you just 10 seconds of this is, these trainers were tasked with coming up with a prevention concept. and they had about an hour to do this, and this is in Tanzania, and what they came up with was a jingle that they could use on the radio about burns prevention, and so I'm just going to play it to you. So just to show you that training can be fun. And then we have we run a one-day course. So this isn't about saving the massive burn, it's about what to do day to day to treat those that have survivable burns. And I've been involved in putting together the manual for that, which is, you know, with the right resources, things that are affordable and achievable in those contexts, rather than saying, you know, you've got to have a thermoplastic splint if you want to prevent contractures. And we run far more detailed courses. We do 5 days of specialty specific work where we go into depth, and that's what I'm going off to do at the end of the week. And we run those in surgery, rehabilitation and nursing, and we're involved at the moment in one for reconstruction. As I said before, it's no good literally just going in and saying this is what you need to do to treat a burn patient. You can find that out from a textbook. People know what to do. What's really important is, why aren't they doing it? We all know what we need to do. We should all be washing our hands every time we see a patient. We should all be cleaning our teeth for 3 minutes every night. Why don't we do what we need to do? So part of the training and the things that we are involved in through the charity are non-clinical things. It's around helping teams identify what the blocks are to changing their practice. It's developing and nurturing a network of people as leaders and helping them with quality improvement projects. And it's being involved in research. So one of the things that we've looked at as a charity has been, is prevention effective? And working with a few villages in Nepal with a prevention programme at the community level, we've managed to not have a single burn injury over a 2-year period in a sort of project called the Burn Free Village. And I'm myself involved in a grant in Pakistan looking at improving burn care there through psychosocial training and sort of psychological interventions with people on the ward. You'll be glad to know I'm right near the end now. And we finally work sort of at an advocacy level with the Ministries of Health as well. So that might be, as it was in Zanzibar, perhaps preparing a report based on evaluating the services and the setup across the country. I spent a year working with clinicians in both the West Bank and Gaza to make burn care guidelines. And this for us at the time was really excellent. This was the first ever project that the Ministries of Health in those two territories had collaborated on. And it's a shame they won't be able to implement them. And we've provided psychological response training in Gaza and in the West Bank for those who look after people with burns. There's a little bit of training how to respond in the event of a mass casualty. So the EU have got this together. The UK isn't part of this because of Brexit, sadly. So although I was a UK faculty member on this training course, nobody from the UK could attend it. And this is helping teams work out what they should be doing if the EU deploys them to an EU country in the event of a mass casualty disaster. And finally, my last couple of slides are around, has this had any impact? And that's a really difficult question to answer, isn't it? One would hope so, but trying to look at outcomes, has it changed, has it reduced mortality? Probably not, because we're not about saving the major burns, but maybe there's been some improvements in mortality because of reduced sepsis, but data collection is an issue. But what I can say in this sort of more implementation science way of thinking is that, the arc of change, as Barack Obama said, is long, and the trajectory of that change is a bit like this. So, you know, it's making a step forward, and then you're a bit despondent because things don't seem to have improved, and then, you know, they have improved a bit. And I think what you could say is we have certainly raised awareness. When I first went to Nepal, it was very disparate. Now there's a burn society there. One of the surgeons from Kanti Children's Hospital is on our board of trustees. We're working with the national training body at the Ministry of Health to implement our training courses in the curriculum, and we've got a sort of countrywide approach to how burn care will be organised in Nepal. But it all comes down to people, as I said at the very beginning. So I think what's really important is nurturing the relationships. This is Zifali, who is a nurse in Malawi. She just attended one of the courses, and over about 8 years she's been invited as faculty to different courses in the world. She's had the personal development and the mentorship that means that she's now in a position to run a significant course in her own country and has been rewarded by Malawi for that. And we asked before, you know, why is it that burns don't have surgeons? Why is it such a neglected specialty? Well, part of it is, from what I've been explaining, burns is very heavy, it's unglamorous. You know, your patients still have a long way to go in terms of optimal outcomes, and there is no private practice. So I think it takes a particular type of person to be encouraged into the specialty. And so this, you know, is a whole group of people from around Southeast Asia getting together where we're saying, look, you're not on your own trying to do this very difficult specialty. We're all in this boat together, and if we all work together, we can bring about those changes. We're not the sort of charity that can say, look, this is what it was like before and this is what it's like now. Isn't that marvellous? I mean, if we went out into the surgical mission and corrected the contractures, everyone would feel great. What we're saying is, if we put all these things into practice, maybe we can stop these awful things happening. That's not very sexy. It's very hard to convey to donors, but I believe it is the only way that we're going to bring about the change. And everyone likes to finish with a quote, so I'm going to finish with a quote. And actually, this is from a quote looking at health, from a paper looking at health inequity in the UK. It's nothing to do with global health, but the sentiment is exactly the same, whether it's in the UK or whether it's global health. And the sentiment is that, you know, health inequalities are not inevitable, and they do cause, you know, significant problems, and putting it right is a matter of social justice. And as health professionals, we can do our own little bit to try to make a difference. And people say, well, you know, we can't afford to do that, but actually we can't afford not to do it. So thank you very much for listening to me.
Sian, thank you very much for really one of the most emotional and stimulating talks I think we've had in my year of doing this. I'm sure that we will have questions from the audience, and I invite people to just stick their hands up, make themselves known and shout out.
I'll start things off.
Dr. Chris Evans.
Thank you very much indeed, very comprehensive review. I can see that prevention, of course, would be the ideal. And for 20 years or so, we've been contributing through our daughter, who was a solar energy guru at one time, to Solar Aid, providing solar battery lights at about £5 a go to the whole of Central Africa, and thereby stopping the use of kerosene. And there have been remarkable improvements, and as well as the reduction in burns, the educational possibilities for kids learning at home with a proper lamp rather than a kerosene burner. I wonder whether or not you've had any experience of that. It's called Solar Aid.
No, I've not seen it, but I mean, it sounds amazing, you know, because changing the kerosene lamps is a really big issue, and you know, certainly I've seen lots of different prevention projects trying to change the way the lamps are made or not using kerosene. I haven't seen a solar one, and I think what is really frustrating is the way that global aid is focused towards certain areas, and that, to me, this feels a very neglected field, because we've seen in high income countries that prevention is totally possible, and so what you really want is some of the big donors like Bill Gates or who are so involved in global aid to take something like this on and really make a huge difference.
When you worked in countries with a kind of different climate to the UK, with high temperatures and things like that, what's the surgical experience like in terms of temperature regulation in the theatre? And then following from that, when patients are dealing with complications, is it because of that increased the heat, does that lead to more kind of, would you say there's an association with complications regarding dehydration and things like that?
Well, I can't quote you, evidence behind that. I mean, I think that it's not so much. I don't think the temperature, for the dehydration makes a big difference in the acute stage. Once they get into hospital, it is warm, and I suppose in a burns capacity that's good. What's not so good is the humidity and the sort of environment that the bandages might be in, so more prone to infection or Pseudomonas colonisation from having a wet bandage in that type of environment, really.
Yeah. That's something that's in the back of the mind, I suppose, is to very nice hospital theory and ventilation.
Yeah, that's right, and it is variable, isn't it? I mean, I've showed you a government children's hospital, and that's fraught with lots of the problems that you experience if you're trying to improve care in low resource settings. Whereas, up the road there'll be a private medical college that's got really excellent facilities, and the staff who work in these places are knowledgeable and skilled people. It's just that, there's so many other blockers to being able to do the right thing.
Do you think that you were speaking about that synthetic skin that's just been developed in Australia?
Yeah.
Do you see that as a kind of panacea, or are there still those roadblocks because of, you said it was a cheaper option than the kind of 2,500?
Yeah, no, that probably will have a significant impact, because the first one that I showed you, that is not going to work in that environment. There's lots of reasons why that won't work. It's very prone to infection, and it's really expensive. So yes, this artificial skin probably will help a little bit, but you've still got to have a skin bank, really. So a skin bank's probably the first thing that you need. That artificial skin will help. It's cheaper, it's quite robust, it probably work well there. But you've still got a skin graft on the top of that. So, it's only the dermis. So once you've put that on and you've taken off the silicone, you've somehow got to find enough donor sites from other areas, or you might have cultured skin, so you've still got that sort of high income requirement. And there is a fully functional 3D proper skin that's been made, that's synthetic, and it's made by a guy called Clement Schistel in Switzerland, but it takes a few weeks to do, and it's super expensive. So in that 5 weeks while you're waiting for this skin to be made, patch by patch, you've still got to do something else, and that something is donor skin.
Sorry, just on the back of that again, in Kathmandu and his works are working currently, what's the attitude amongst others around donation of skin to allograft material? Is there kind of a taboo around that, or is it donors?
I think sometimes there's donors, so you can use a family donor. It's just not as effective as if you take a fresh donor skin graft and you put it straight on. Generally, that's not going to do very well. It might do well on a big burn that's immunosuppressed, because they're not going to reject it so much, but it'll only be a temporary cover. When you get it from a skin bank, it's been processed, so its sort of length of stay on the body is going to be longer. But yeah, some people will donate, and there are skin banks, being set up now. There is one just being developed in Nepal.
I was going to invite a professor from Yemen, Professor Issatrop, who is visiting from the Yemen. We're very fortunate you've come across an alumni of the University of Liverpool as well. Did you want to ask a question? Because you bring the international perspective this evening.
Thank you so much. It was really So my question is, which is the preferable time between the patient and the operation? Is it to be immediately, or there is still preferable time until the operation will be done? This is the first part. The second part, the first or second view of burn, is it preferable, which is the major area, mass area? Is it preferable to be covered or to be exposed? Because of, sometimes to be infectious, sometimes if it is covered. So our experience, if it is exposed, the skin will be healed so soon. But what about your experience?
Okay, so for the first one, it depends a little bit on depth and area. In bones that are full thickness, you're better off having surgery to get rid of it, and once you know that, it's better to do it earlier rather than later, but you have to have a plan to put a skin graft on. So if you're in a war zone, you haven't got those facilities, then you might not be able to do it at the optimal time, or people might come to you quite late, in which case you might do the debridement but not put a skin graft on at that time initially, so that it's you haven't got such a heavy bacterial load. So I think, in those environments, it's hard to say what optimal is. I mean, optimal in an ideal environment would be immediately, really. Once you absolutely know it's deep, then you do it within the first few days. So ideal results are really within the first 7 days. You would want it to be taken off. And the second one, I think there's variability in practice. So if you're in a clean environment and it's quite shallow, you can leave it exposed and it will crust over. But if it's deeper or quite mixed in area, then I would say it's preferable to dress it. But we leave facial burns exposed in little children that are quite shallow, because it's quite hard to bandage it up and they don't like it. But I've seen bigger areas exposed. But I think clean, dry environment, you can leave it exposed. Yeah. But both methods are okay.
I saw a hand up in the middle of the audience.
Yeah.
Go.
Some 50 years ago, the daughter of a friend of mine, they sadly died for a fancy dress costume inflamed. How satisfied are you now with the state of the clothing industry in this country? I have a very selfish reason, because I have a 4-year-old granddaughter and I want to protect her as much as possible. How safe are our children's clothes now in the UK?
I think clothes manufactured here generally probably safe, pretty good. Fancy dress costumes, absolutely terrible. And the other thing is, a lot of the Indian clothing, the salwar kameez and clothing imported from abroad, they're also very poor quality. But I think generally, a lot of kids' clothing is quite good. Fancy dress costumes, definitely not. That's really sad.
I was going to ask a question, but
Go ahead.
no, ladies first. Go on. You go.
Forgive me, I'm not from the medical field. I'm actually here doing a bit of research. I'm currently developing a television program, actually, a medical drama for Netflix. So what drew me in was your title for this lecture, so I was really intrigued and this fascinating lecture. And you did speak briefly about the stigma around burns and stigma. I wonder if you could talk more about that in terms of what you would like to say to the public who may be watching this program, and also talk more about sort of the pressures on staff in those situations.
Yeah, I think what I'd like to say, I mean, I think, like I was saying, it's very natural to have that inhibition and to look at people who are different, and your eye can't help it. We form faces all the time whenever we look at anything, don't we? But our eye is very practiced at picking out things that are very different. And I suppose my message is to try to overcome that instinctive reaction, because when you're prepared, you will you'll do that. You know, if I said you were going to come and meet somebody who's, you know, been beaten up and looks terrible, you'll be prepared mentally to see them. But if you suddenly see someone on the street that's not what you expect, you can't help but look twice. But I think you can modify how you do that, and you can also talk to people as normal, because I think the other thing about stigma is just assuming that that's not a normal person that you're talking to when it actually is. And I suppose even if you do that thing, you know, you then just speak to them normally, greet them like a normal person, and that's probably my key message. And I think for staff, are used to it, I suppose, and we understand what people are going through, and we hear a lot how people struggle with appearance, and it isn't just for burns. So I suppose that's the other thing to say. You know, anyone involved in any kind of aesthetic surgery, you know, plastic surgery that we do, we're always seeing people who look different. Everything we do is about making a plastic surgeon basically is trying to change the outside of a person so that they look better. You might do it inside, but the net result is on the outside. So I think for staff, it is, I would say most of our staff don't go away looking at people going, oh, you know, they look terrible. It's not how you think about a person.
Only because you mentioned about the nurse and hair.
Yeah, because I think what's interesting there is, and you know, I couldn't elaborate in it, is that, you know, that nurse is an ICU nurse, so she's seeing one little aspect of somebody's care, and you know, it's that's why, you know, when we've had some major burns patients, I will take them back to ICU to say hello to the people that cared for them, because you don't see that. And I think what you do see is you see the rather terrible side of things, people coming back with bandages, the rather, you know, it's extremely quite traumatising, I think, being in that environment, especially when you don't get to see the end result, if you like. You don't see people as people, you only see them in that rather catastrophic situation. So I think, you know, her response, I don't want to be making it out that she was terrible. I think it was a very natural response, and I felt, you know, my job is to say, look, it's actually okay at the end of the day. I mean, that's what we do as plastic surgeons. We predict what things are going to be like. We say, oh, don't worry about that scar, it's going to look fantastic in a year. You know, that's not what a person wants to hear, but we know that it will look better. So I know that I'm looking at this terrible situation, but it's going to be a lot better, you know, in 2 years' time. But an ICU nurse doesn't know that. And I think my big message would be for dramas, television programmes, documentaries, to stop portraying scarred people as villainous, and start having some scarred people who are normal heroes of the story. Or not even heroes, just normal people. You don't have to be heroic because you've got scars.
Thank you. So one of the great pleasures of these evenings is I get to drag you down to the front, in front of everybody. So come with me. And on behalf of the Liverpool Medical Institution, I get to present you with a medal.
Oh, thank you very much.
Everyone that's done a President's Lecture gets one of our medals, and you have to do a cheesy photograph in front of the floor. That's your medal. What a wonderful lecture. I really good science, good change, audit cycles, outstanding outcomes, but still so much that needs to be done, and so much opportunity for improvement globally. It really gives the youngsters at the front row, and I have brought you down deliberately to pick on you, something to aspire to. And that's also a portfolio career, someone that starts off as a surgeon, becomes a paediatric surgeon, but has an interest in history of medicine and tropical disease. What a career! There you are, and all four of you are ladies as well. It just shows that this is where the future lies. Thank you. Now, those of you that aren't medicine are now obliged to get out your phones, and if you scan that QR code with your phone, you'll find a very easy way of applying for membership. It is free for medical students. For allied health professionals, it is about £45, and for doctors in training, I think it's gone up to £48 now. for which you will get, I think it's 18 lectures, which include 2 glasses of wine. So if you can get 18 times 2 glasses of lecture, as a Scotsman, I can tell you it's the best deal going in Liverpool. Okay. The other thing I have to say, I just want to thank you all so much. I've thoroughly enjoyed being your president for a year. It's been great fun. It's been great getting to know you all. And so my thank you. And Mr. Machin wants to make a few comments as well. Derek.
Thank you, President. My name is Derek Machin. I'm a retired surgeon, and in this building I chair the council. Now, I wasn't actually intending to make any comment about the lecture, brilliant and inspiring though it was, but I then thought, actually, I have insight into this area that probably nobody else in the room has. Because just on 50 years ago, when I was training in surgery, I rotated through Alderhay Children's Hospital. And part of the training was on the burns unit, which was run by 2 very kind, very well-meaning general surgeons on a very, very part-time basis. And frankly, it was really at the level of cottage industry. And when I saw what was going on now compared with then, it was just incredible, because we used to take the poor children to theatre often several times a week to be debrided and to have skin grafts done. And if the burns aren't bad enough, okay, they got a general anaesthetic while the grafting is going on, but just think what raw areas are like several times a week. It's awful. So I'm delighted to see how things have progressed. I know in my own specialty of urology we've progressed unbelievably over that 50-year period, bringing in all kinds of advances in optics, minimally invasive surgery and so on. But I personally had no idea that the advances in burn surgery were anything like the same level. So that was really inspiring. What I was actually standing up to say was that, as Callum said, this is the last lecture of the series. And this has been a remarkable lecture series. Yeah. We have had recovery post-COVID. COVID really hit this place very hard and continued to hit it after the infection itself had died back, because people were reluctant to come to meetings with other people, and everybody was worried about getting COVID. And there's quite a lot of our members are of a certain age. They were particularly vulnerable. So we've had a prolonged post-COVID hiatus. And Callum has done a remarkable job, because he's put on one of the best, if not the best, lecture series that I've ever seen here. And he's also encouraged so many of the medical students and people from other disciplines to attend. So Callum, thank you very much indeed. You've done an absolutely splendid job.
Ladies and gentlemen, thank you very much. You are dismissed, but thank you very much for your attention this evening. Please do become members. Although we can keep our heads above water as a conference facility, we only really exist as a membership, as a membership of this institution. And if people don't want to come to lectures and don't want to come to the institution, we won't exist. So your support is actually what keeps us going. And I think we are meeting the needs of our statute, which is to provide medical education in convivial surrounds and to encourage good medical society. It actually says good medical intercourse but let's accept that was the 19th century interpretation of that meaning. Just before we go, there's one person I do also need to thank. That's Deborah, my wife, who has been so kind in accepting that 2 nights in a month I disappear to come over here for my duties. And thank you very much, Deborah. So it's nice to see you at the back. And you actually had a job to do tonight as well. You were first aid superintendent as well. So thanks. At least one of us knows what to do in a medical emergency. Thank you very much. Thank you, everybody. Good night.